Greetings everyone. Welcome to the 123rd session of the online Optom learning series, OOLS. And for today's session, we have with us Professor Govindaswamy Kumaramanickavel. Dr. Kumar, I think I know him as Professor Kumar or Dr. Kumar. That would be much more easier. He works on ocular genetics and he's primarily involved in gene mapping, mutational screening, and association studies between the genome in complex ophthalmic diseases. He is the director of research at the Narayan Nethralaya, Bangalore, India. He was a research fellow at the Ocular Gene Mapping Laboratory, Department of Biochemistry at the University of Otago, New Zealand. He is involved into gene and gene mapping for many years at this point of time. He is involved in glaucoma, diabetic retinopathy, and pediatric epidemiological and genetic research projects with these involving gene therapies for about 35,000 subjects. A vast experience over 30 years. He has done genetic counseling for over 12,000 patients. He teaches medical and ophthalmic genetics in India and also several other countries overseas. He finished his graduation in medicine MBBS from the University of Madras at the Madras Medical College, India, and subsequently graduated in MD. He is a visiting professor at the Chinese University of Hong Kong and Sri Balaji Medical College, Hospital and College, and various other several universities in India and in China. He has received funding for his research projects from the Government of India, National Institutes of Health in the US, INSERM, France, and other private funding agencies as well. With all that expertise, he has over 120 peer-reviewed publications, which includes article in Nature Genetics. He is recognized for his PhD, and he guides several students for the PhDs in India as well as abroad. And with all that heavy experience, Professor Kumar is going to talk to us about the clinical aspect on how should we go about handling a patient when we see them. And I think quite often as optometrists, as primary care practitioners, wherever we work, we do encounter patients with genetic disorders, and he is going to take us through on how do we handle these subjects, what should we go about looking for. So welcome Dr. Kumar onto our platform. Let me just leave the screen time to you.
First of all, namaste. And thank you, Fakhruddin, for giving me this opportunity, and particularly the online optometry learning school. It's a great privilege and good opportunity for me to interact with people in optometry and to make them understand that how important genetics is from the clinical point of view. And therefore, my talk, as captioned here, will be looking at how to clinically handle a subject with a genetic disorder. Genetics is, quite neglected in the field of medicine, not to mention ophthalmology or optometry, all over the world. So let me take you through the journey today and show that how much important role a geneticist or a genetic counselor can play with the family. So I have actually structured my talk as you can see on the screen. And from the basics of ocular genetics and genetic counseling, so how we do it, onwards, I'll also be talking about how we are handling patients. These are recent patients, most of them, and therefore you'll be able to understand as an optometrist that how you can handle tomorrow, or you can guide and direct them over to the right expert so that all the help is provided to the patient and the family. And of course, at the end of it, I'll be talking about how the current scenario of genetic counseling practice has changed compared to about 30 years ago or 20 years ago, including developing countries like India. So, therefore, today, the technology in the field of genetics and genomics has advanced so much that it's very easy to do these tests. And the problem is to interpret and then translate that to the patients and the family. First of all, let me talk about the basics. And therefore, if you walk into any population across the world, you'll find four different types of genetic disorders, whether it is KL or Chennai, where I am in India, or in Beijing or London or New York. You'll always find only four different patterns of genetic disorders. So the first category, as you can see, are chromosomal disorders. And as optometrists, most of you would have seen people, children with Down syndrome, who may develop squint or might later on, very early in age, could develop cataract and so on and so forth. They can even develop floppy eyelid syndrome because their muscles are not strong, and therefore they have drooping eyelids to a certain extent, or they don't really close them very well during sleep. Now, the second category is a single gene disorder. A huge number of disorders come under this category, and there are about more than 15,000 disorders. Some of them are common, many of them are rare or ultra rare disorders. As optometrists, you would have seen very often color blindness, sometimes galactosemia, retinitis pigmentosa, most often, and then retinoblastoma as well. And you may come across sickle cell disease because it can occlude the material in the retinal blood vessel, and therefore they can lose a segment of their vision and therefore come to you. And I know a colleague of mine has identified patients of that nature. Later on, when it was investigated, they found it was sickle cell disease. Okay. So optometrists can play a very big role because you're the first line of screening, and therefore you raise a flag on genetics, suspect something is genetic in nature. All that you have to ask is simple question. It doesn't matter whether it's myopia, or it is glaucoma or retinitis pigmentosa, night blindness, and so on. So all that you have to ask is there anybody else affected in the family? If they say yes, it's better you draw a pedigree. Okay, it's not very complicated. Or write at least in the case sheet or in the EMR that there's one more, two more, three more members affected. I'll come to these things later on as I proceed. And complex disorders are extremely common compared to chromosomal single gene. And it's almost 1 in 2 if you take populations above 50 years of age, starting from age-related cataract, coronary artery disease, diabetes, or diabetic retinopathy, glaucoma, hypertension, and neuropsychiatric or malignancies. That category of complex disorders are pretty prevalent in a population, whereas chromosomal single gene, the fourth category is mitochondrial disorders like LHON, or Leber hereditary optic neuropathy. So these that three categories, chromosomal single gene, mitochondrial, are seen more often in a tertiary hospital rather than in your own family or, or your neighbors or your friends or your classmates and so on. But complex disorders are very common. You can find multiples of them in your own family. You don't need to step out of your house or your family to find somebody who is affected. Now, this is just for the students who want to just to brush up their knowledge, what would have been taught to them in their school. Humans are made out of multiple cells, and all that together forms a tissue, organ, and then we physiologically function as a human being and have perfectly normal vision or normally beating heart from birth till death, or the function of the lung or whatever. Okay, but each of those organs have a cell, and as you can see here, and each of those cells have a nucleus, and inside the nucleus you have the chromosomes. And if you unwind the chromosome, then that will become a single DNA thread of four letters, as you can see here, AGCT. So you can have chromosomal disorders like Down syndrome, or you can have DNA letter words like single gene disorders, or complex disorders, or mitochondrial disorders. Okay, chromosomal disorders are a major category where one single chromosome may be present or absent, or a segment of a chromosome can be lost or can be extra. Now, single gene disorders, complex disorders, and mitochondrial disorders are DNA letter defects. Okay, that's to talk in a very broad way. So therefore, in a population, you would see these disorders quite prevalent, particularly the complex disorders, as we mentioned earlier. So I'm just showing only a few examples of these disorders. So one of the chromosome disorder, as you can see, is that we all have about 46 chromosomes, and then children with Down syndrome have one more extra chromosome in 21, and therefore they have 47 chromosomes. And these are the gender chromosomes of X and Y. So this is a child with the floppy eyelid syndrome, as I was talking to you about, very classical Down syndrome. You karyotype them, you'll find that they have one extra 21, and that's because when the mother crosses 35 years of age, she's highly risk prone to have children with Down syndrome abnormality. And there are many biological reasons why that happens. So anyone can guess what this is? Okay, many of you might have actually recognized that. So that's a typical Marfan syndrome. These are excessively tall individuals because they have a connective tissue defect. It's a single gene disorder, Marfan syndrome. And then if you measure their arm span from tip of the middle finger to the other tip of the middle finger, then you'll find that arm span is longer than the height of the individual, which is not the case with normal people like us, where the arm span will be lesser than the height. Okay, so they have, it's a connective tissue disorder, so a lot of laxity will be there in all the connective tissue that is there. They can flex their finger and touch their back of their arm, and they have, because the suspensory ligament of the lens is very lax, they can have subluxation of lens, so they will come to you for visual disturbances. And they also have cardiovascular issues as well. So it's a single gene disorder, and in single gene disorder, there are three different types of inheritances, like autosomal dominant, autosomal recessive, and X-linked recessive. So this is an autosomal dominant condition, so you'll find multiple members in the family who might also have a similar problem, okay? And they definitely need a reference to a geneticist. Yeah, so all of you would have, quickly guessed what this is. It's obviously retinitis pigmentosa, and you can see these people will complain of night blindness, and obviously there might be a 50% chance of family history, so please don't forget to ask them. And then you will find pigments, okay, as shown here, mostly mid-periphery, and then you'll find attenuated arteries, which are very typical. So they gradually lose vision, and it can lead to total blindness as well. Okay, so is counseling easy or difficult in ophthalmology? Well, the answer is, it's sort of easy, at the same time it's difficult as well. Okay, and I'll tell you why. But first of all, as an organ, eye is one of the most complicated one, very privileged. You don't get anything that it's got a huge visa issue. Okay, so it doesn't allow anything to get in very quickly, and at the same time, it doesn't also allow anything to get out. Okay, it's a lot of things are good because of that we can do gene therapy, and it doesn't sort of get systemically. Okay, so there are a lot of good things because of this barrier, retinal blood barrier. But then the function of the eye is so complicated, okay, extremely complicated. No other organ can come anywhere close, whether it's heart or liver or anything for that matter. So each part of the eye has its own function, as all of you know this better, is that the corneal function of transparency is something very amazing. And then there is nothing in the body as a sensory organ that can sense photon, okay, except for the photoreceptors. So there are a lot of uniqueness of the eye as an organ, and therefore its genes are complicated. Okay, so there are probably about 15 to 18,000 genes that are there in human body, and nearly 20% of them, as you could see, about 500 or more, relate specifically to the eye. And therefore, if you see from the lid onwards till the optic nerve, there are many genes which play a very important role in the embryological development till the, sending the photoreceptor signal, converting that into an electrical signal and passing it over to the occipital lobe. So therefore, you can see that two organs specifically take a bigger role. They are the active participants or the key heroes of the eye as an organ in terms of genetics. So you can see more than 100 genes for cornea and more than 200 genes for retina. And some of these can be syndromic as well. Okay, not necessarily specifically with one particular component of the eye. So let me move on to change gears and move on to the topic of the day, is that what is counseling actually? Well, counseling is a very, different procedure in the field of medicine. It can be used in many, it can be psychiatry, it can be, oncology or whatever, but then it is also used in medical genetics for genetic counseling. There are many things that are very, very different from how we do practice in the field of medicine, or for that matter, ophthalmology, optometry, it doesn't matter. So therefore, if you really see how it differs, is that unlike, an ophthalmology patient comes to you with cataract, you see them, and then you do a surgery, they become all right in less than about week or so, or they come to you with a refractive error and you correct it and they become all right in just about half a week or so. Whereas here in genetic counseling, that's not the case. The patient comes with a problem and they will walk out with the same problem, and you should make them satisfied. Okay, it's pretty tough in some way, and it's not that all of them will be very happy with what you tell them at the end of it, because you're not solving their problem in almost 99% of the cases. Okay, so but then primarily what you do in genetic counseling is that you talk to them about the relative risk. Okay, so what's the chance of it being passed on to your children, to the next child, or to the third generation, and so on. So that inheritance potential, how it is happening, is very mathematical, because Gregor Mendel told that how this is being inherited. Okay, so it can be a single gene disorder, it can be chromosomal disorder, mitochondrial, or it can be a complex disorder. Each one of them have a particular way by which it is transmitted. Now, coming to complex disorder, very difficult to do counseling. I'll tell you why later on. But single gene disorders you can do very precisely, and so for mitochondria and chromosomal. Okay. But the fact here is that how does it differ? Okay, everybody does talk to patients. You tell they have myopia and how it can be corrected. It will be continuing as far as the person is growing, and all that is something. It's all part of counseling that that we do. But here, Unlike you prescribing uh, spectacles, okay, and then giving all the specifications, and where the patient doesn't make any choice. So you tell them what to do, you tell them what drug to take, you tell them what surgery they should undergo. But here it's not like that. It's almost like walking into a hotel and somebody gives you a menu card, not somebody, the waiter gives you the menu card. You pick and choose what you want. Okay, and there are half a dozen of them where going together. Each one will pick what they like. Okay, it's the same case here. So most of the times, patient doesn't come alone. There's a family member or a couple of family members, and therefore each one like to have their own choice of what to do depending on the age of the patient, whether it is a child or an adult or a teen, and so on. Okay, so therefore we are supposed to give the information, and the autonomy of what to do is left to the patient as well as the family. So that way it's very different. Okay, in today's Google world, they will know more than what you know. Okay, it's not uncommon to see that. I have patients of that nature. So they all put themselves on a prompt, okay, digital prompt, and they get one news about some therapy somewhere in some corner of the world. I will get a WhatsApp message or an email asking that is this something that they can try or not. But so we really take that very easily. Many times people get upset about it, but then we don't, and therefore we try to see that and understand that that's the autonomy of the patient, and therefore we can't trespass into that. Now, this is how the counseling process runs in a clinic. And first of all, you evaluate, which is primarily done by the physician or the optometrist, and therefore they come to most of the times come to a clinical diagnosis, okay, until otherwise it's a rare disorder. And I have come across a couple of situations where we have discovered an RP patient having mild deafness of Usher syndrome or Bardet-Biedl syndrome, the extra digit, and so on. Okay. Then we do investigations, we do genetic tests. I'll come back to this exactly how we do it, I'll say later. And then we give them all information about the disease, the natural course of the disease, and what can happen and what cannot happen. Particularly, as you all know this better than me, most of the times the question from the patient or the family is that whether the person will become blind or lose the sight. Okay, so therefore, most of the times we don't do genetic counseling in one sitting. Okay, we take a bit of a time. I'll tell you why. And then the decision of what to do, whether they want to do investigation, they don't want to do investigation, they want to do a prenatal diagnosis, they want to go and adopt a child, is a decision left to the family and the individual. So this is exact flow with which we do in our clinic, and I practice in multiple places in India. So therefore, and of late, with thanks to Corona, we have almost 1 and 2 counseling, which is online, and therefore we can do genetic counseling sitting here with somebody in your group who wants to take care of a patient, whether they are in Philippines or Vietnam or Kuala Lumpur or elsewhere in the world. Okay, today it doesn't matter. I do counsel patients like that. Okay, from Africa and so on and so forth. Okay, so when a patient arrives, we have to be very clear that all the case reports are there. Okay, so we don't take it for granted when patient tells that I have RP and so on. So this is for professional reasons, and secondly for legal reasons that we need an authentic diagnosis. Okay, and almost 2/3 of the time it's done. But again, having said that, most of the times, if you get a diagnosis like retinal degeneration, that's not a complete diagnosis. It has to be RP, or it has to be, Stargardt's, or it has to be, specific diagnosis, because each one has its own inheritance pattern. So we are very, very careful about ethics, okay, confidentiality, privacy, like any other field of medicine, but extra care is taken here because of the nature of the disease, which is genetic, and therefore we brand somebody with an autosomal dominant type of inheritance, then that's for the lifetime that they get that. So we literally in our genetic counseling brand somebody, which is very unfortunate. So we take very much care, because if you take sickle cell disease, it's much more common in the African Americans in the US. And therefore, some of these disorders can have a racial predilection, and therefore that can have an impact on the individual's social living as well as their professional existence in terms of their job and so on. Okay. Anyway, so we draw a family tree, which is the pedigree, and this is very important. Not very complicated. It's you can learn it in less than half an hour, and all that you need to do is talk to them very patiently to get information. Okay, most of the times husbands are really bad to tell their own family's family pedigree, and most of the times I've seen, still I don't understand why the wife tells the husband's pedigree much better than the husband itself. Okay. Anyway, so once we have the pedigree, we know the inheritance pattern, chromosomal single gene complex, or it is mitochondrial. Okay, most of the times. So then we look at the detailed medical records. We know the diagnosis, we know the inheritance, and we sort of clip them together. And then we say what is the inheritance and what can be the chance of it being transmitted, what genetic test can be done, and then what is the rehabilitation, like visual rehabilitation, low vision clinic, these kind of things. They can be referred by the ophthalmologist, optometrist itself. Sometimes they do escape all that, for reasons unknown, particularly in a country like India, and they come to us straight away. And therefore, we let them in to the guidance. For example, you take Down syndrome children. Some of them can die because they don't know how to swallow, because they have a very lax muscle. So they have to be given swallowing rehabilitation, okay, as kids, and therefore we refer them to such kind of centers where they get help. Not too many you have in a country like India. So major cities, urban cities like the one Chennai where I'm living, you have. Now the patient can exit at this stage, okay, because we can tell the inheritance chances and all that. So genetic test is not mandatory, unlike most other fields of medicine. One more difference again. And if the patient feels that yes, or the family, we'll do the test. But we, as professional genetic counselors, make sure that the benefit goes to the patient, okay, which is called as clinically actionable. Okay, let me tell you what the term means. It means that I'm coming with RP. I'm sorry. Let me take, for example, I'm coming with retinal degeneration because I'm in a very late stage, and therefore the optometrist, ophthalmologist could not diagnose whether it's a rod cone or a cone rod, because literally the entire retinal layer is lost in the OCT, so they are unable to diagnose. So they come with a broad diagnosis of retinal degeneration. So sometimes if the pedigree is also ambiguous, we cannot properly give a counseling. So we can do a genetic test and find out what the mutation is, so that we know that it is Stargardt's disease, because ABCA4 mutation can be there. Now, for that reason, we don't do it, because it's an expensive test. In majority of countries I know, including US, it's not covered in the insurance, so people have to pay out of the pocket. In a country like India, it's 25,000 rupees. Okay, a couple of $100 US dollars it will cost. So most people cannot afford. Okay, but these tests cannot be made cheap because of the infrastructure, the personnel, because it has a wet component of the lab and a dry component of the bioinformatics. And you have 2/3 of people in bioinformatics than in the wet lab. Okay, so it's a very expensive infrastructure, and naturally the costs are very high. Okay, so therefore we don't do the test for us to come to a diagnosis. Okay, until otherwise the patient insists or the family insists, and show you some cases to understand that. So depending on the inheritance, it can be, you can do a chromosomal test, or if it's retinoblastoma is one gene, or it is Stargardt's, it's one gene, usually one gene. Okay, mostly ABCA4. There are very, very few minor genes. Okay, but then you can do gene panels. There are about nearly 100 genes for retinitis pigmentosa, both syndromic and non-syndromic. And then you can do what is called as whole genome, whole exome, whole genome, or clinical exome. Okay, we generally do clinical exome because that's cheaper. It covers about most common 7 to 8,000 single gene disorders, which are called as Mendelian disorders. So once we get the test result, then we get into a post-test counseling. Okay, so this is the reason why I told that you can't do in one sitting. Okay, even pre-test counseling, it is better that you can tell that you can do it a couple of sittings. Okay, the reason is that they'll come back to you and say, look, there is somebody, I inquired my grandmother and she told that there is someone else in the family who was affected and they are dead. So most people don't know. So therefore, we shouldn't actually do one sitting genetic counseling. Okay, it's a very bad practice to do. So once you do the test and you get the result, then you sit on post-test counseling, and then you can, extremely be confident of the inheritance. And the genetic result can be interpreted, and then accordingly, you can focus on the guidance that is necessary for the individual and the family. Okay. Now, I told earlier that is ophthalmic genetic counseling easy or difficult? And then I said that it's easy, but at the same time difficult. The reason is that, as you can see in the slide, so retinal degenerations have something called as clinical and genetic heterogeneity. Heterogeneity is an opposite term of homogeneity. Homogeneity means that everything is equal or even or similar. So heterogeneity means something that is very dissimilar, and this is a very, very common term we use in genetics. Okay, so when you say that heterogeneity clinically means that there can be several presentations of the retina, which will look like retinitis pigmentosa, look like cone rod dystrophy, look like rod cone dystrophy. Somebody with very poor experience might diagnose these things interchangeably, okay? Or even with good experience, people can make mistakes, all right? Until they, otherwise they are specifically trained on retinal genetic disorders, okay? Where you can do these things in very good eye hospitals like Moorfields and so on. So genetic heterogeneity is that one gene can cause multiple clinical phenotypes or clinical presentation. Okay. For example, as you can see these circles here, so you can take a gene like rhodopsin. So rhodopsin can cause retinitis pigmentosa, and it can also cause congenital stationary night blindness. Okay. So therefore, when somebody comes and does a genetic screening and then comes with rhodopsin mutation and wants to know what the child is going to get, you have to be pretty guarded. Okay. If I'm the person, I would rather have congenital stationary blindness so that I can have vision until the end of my life, rather than RP, which is progressive and I can become blind. Okay. So, and therefore, this heterogeneity makes a lot of things very difficult to give a clear answer. So you cannot do a counseling saying that you may get it, okay, you may not get it. I mean, this is something which is going to put the patient and the family off, okay? So you have to be not in the gray area, but in black and white, okay, black or white. So you have to say yes or you have to say no as a counselor. So you can't say that maybe not. Okay, that's a very bad way of counseling. Okay, you'll really be very cutting a sorry figure with the patient and the family, and it's not uncommon to come across this situation. Okay, Now, if you take the photobiology of the vision, and as you know that there are two major components of phototransduction pathway and visual cycle. So phototransduction pathway with multiple genes, as you can see in this diagram, happens in the retina. Okay, yeah, the retinal vascular layer, and therefore it is one of the key components of picking the photon, particularly the rhodopsin molecule is stimulated by the photon. Okay, so and there are many other key stakeholders in this, and everything has to be recycled, and therefore it happens in the retinal pigment epithelium. Okay, so this is a topic by itself to talk from genetics point of view, but I'm therefore not going into the detail. But all of you have to know that, see how key each gene is. So if rhodopsin doesn't work and there is a mutation, then the rest of the pathway, though if it is all the genes are intact, it doesn't help. Okay, so therefore the rhodopsin molecule goes in a fast forward manner despite it is mutated, and therefore it triggers apoptosis, and then it leads to rod degeneration and subsequently cone degeneration. Okay, so therefore obviously they'll be losing vision and coming to you with night blindness or reading blindness and so on. So if you look at these genes more carefully, you can see that they play a very critical role in each part of the photoreceptor or the retinal pigment epithelium. As you can see that there are different genes playing their own part. So that's a nucleus, and that's where all these genes are produced, and they travel up and then they go over. So they can, any of them, particularly this part of the connecting cilium is actually a cilia. So really speaking, that's a ciliary nature. So these genes can, if they are mutated, can cause Bardet-Biedl syndrome and other condition. Okay, and therefore there is another category of disorders in genetics called as ciliopathy. And because Bardet-Biedl syndrome, this cilia is a mutation in one of the genes of the BBS. Okay, it's called as BB-SOM. And because we have multiple cilia in the body and they can be infertile and they have a new finger that's coming up and so on and so forth, therefore it becomes syndromic and much more systemic in nature and not limited to the photoreceptor alone, okay, in the defect or the mutation. So therefore now let me move from the basics on to a clinical scenario, okay, and see that how we handle. It's actually a 4 clinical scenario. Sorry, I've written it as 3. So I'll go through each one of them, and you can see how things can be very different when you bring this knowledge of genomics into the clinic and talk with your patient and family. Okay, doing research and identifying genomics is one aspect of it. But if you really ask me, it's a sad story what has happened in genomics. Okay, I've been in this field for the last 30, 35 years, from a very, very poor knowledge time onwards till extremely good knowledge in genomics today. So what is the sad story? So the sad story is that we have tons and tons of genomic knowledge. Okay, you can type a gene on the web and find exactly what function it does, as I showed you in one of the earlier slides. But how much of that tons of knowledge has actually gone to the medical personnel or paramedical personnel? Okay, just milligrams, not tons, milligrams. And then how much of that knowledge with the practicing clinician or optometrist has gone to the patient? Okay, so that is in microgram, it has gone. Okay. So how much of this knowledge has gone to the benefit of the public? It's not even, a nanogram level. So why this, translation or the transmission of tons of knowledge has not reached the public who have paid the taxpayers' money to find all these genes and their functions and the therapies that are coming out now out of this knowledge has not reached the people who really paid for it. Okay, and today a patient cannot get insurance money to do a test despite public funding all this. Okay, it's all very sad to see. There can be many reasons. Okay, it's not a topic to be discussed today. So let me move on to each one of these disorders. Okay, so I'm taking retinitis pigmentosa. He is a 32-year-old male, and then they have been suffering for quite some time. The vision is very poor, and I'll show you the family tree. So each circle is a female, for those who may not be aware, and each square is a male. And this line is mating or marriage, and then this line drawing below, and all these people belonging to this particular line are actually children or siblings. Okay, so I can go into the detail of that, but then I'll run too much out of time. And all that you have to understand is that in this family, there are a couple of types of disorders. One is retinitis pigmentosa, which has this particular legend. And then you have myopia with this legend. And then you have suspected glaucoma with this legend. But we are going to look only at retinitis pigmentosa. So retinitis pigmentosa and myopia are associated. Okay, and therefore when we take history, pedigree, we always take information because very early retinitis pigmentosa may not be known. But then somebody at this 32 years has retinitis pigmentosa, then it's very unlikely that people older than them might have missed. Okay, so therefore mostly this might be isolated case with no clear inheritance pattern. Okay, this is almost 1 in 2 patients with retinitis pigmentosa, you find this. So the reason they came to us is that this lady has myopia and this person has retinitis pigmentosa. They wanted to know what are the chances of their children to have either one of them. Okay, so myopia is very difficult to predict. Okay, again, you have syndromic and non-syndromic myopia. And usually myopia is autosomal dominant, and you can therefore see in the family, it's sort of passing from here to there. And on both sides of the pedigree, both on the father's side and the mother's side, you have people with myopia. It's a very common problem and more common in the eastern part of Asia, starting from Malaysia, Singapore, and countries like Singapore, Hong Kong, Taiwan, and South Korea. It's more an epidemic. Almost 70 to 80% of the people have one condition or the other with myopia. Anyway, let me come back to retinitis pigmentosa. So therefore, what we did is we did not investigate myopia. It wasn't too serious anyway. And therefore, we said that we cannot rule out it being inherited. But then we said that, if they are willing, we'll do a genetic test. And they were willing, of course. And therefore, we did the test and we found that one of the photo transduction pathway gene, CNG beta 1, was mutated, of course, with a variant. Okay, we don't use the word mutation nowadays, in variant. And both were in one single copy in that father, okay, in 2 different regions. And this one was pathogenic. That's how they classified as per a nomenclature and guideline. And one was uncertain significance. So this is a nightmare in our field. And therefore, it's very difficult to interpret that. But then with that information, we did counsel them that what are the chances. Okay, so there is a chance and they can go for prenatal diagnosis. Now, let me come to this point of prenatal diagnosis, which you can do in multiple stages. Around 10 weeks, 7 to 10 weeks, you can do what is called as chorionic villus sampling, where you take a sample from the placenta of the mother and try to test it from the fetal side of the placenta. And then you can do it later on, around 4 months, okay, 3 to 4 months test called as amniocentesis. But today people do more chorionebular sampling because if the pregnancy crosses third to fourth month, then there's a maternal risk for abortion. Okay, so anyway, there are choices that the family can adopt. As having said all this, most of the ocular disorders, okay, ocular genetic disorders are not lethal. Okay, so therefore choosing abortion is a gray area. Okay, it's not like a disease like Pompey's disease, which is very serious. Okay, the death is inevitable in the young child, and therefore the parents can choose abortion, and we can support as counselors. But most of the ocular disorders, and including retinoblastoma today, are not lethal. Okay, so we have to be very careful when we do these kind of counselings and try to sensitize the family. Now, not only for understanding what is the chance of this being passed on to the next generation that people come to you for counseling, but today there are genetic therapies, okay, cell therapies, prosthesis, okay, and all that has come in the last few decades, and some of them are very well refined. So cell therapies, stem cell therapy, gene therapies, genetic therapies, okay. So one of the gene, RPE65 gene, is available today for prescription practice in North America for Leber congenital amaurosis and early onset retinitis pigmentosa, where the mutation is in RPE65. And they have to have a fairly functional photoreceptor layer for gene therapy. And in fact, I was fortunate to be in New Zealand to be part of the team that discovered the RPE65 gene. Okay, so we have a publication, Nature Genetics, in 1997, and that was co-discovered at the same time by a group, Ted Dreiger's group in Boston, in Harvard. Okay, so for this reason, for therapy, people come to you for doing genetic tests, and that's something we are seeing of late, and particularly me, we are seeing it pretty of late. So here's a family. I'm not going into the detail, but what point I want to make is that the father is very minimal vision. Okay, probably 10 degrees, not very. It's not 6.6. Okay, it's much less than that. And N6. Okay, he's pretty below par in that terms. So he has a Usher syndrome mutation. He doesn't have deafness, but only retinitis pigmentosa. He's worried about his daughter. The inheritance of this allele is little complicated. I'm not going into the details because of time. But the point is that he's a jeweler, very extremely rich person, wants to go for gene therapy. And now for Usher syndrome A, for a particular mutation, there is a treatment clinical trial available by a company called as ProQR in the US. Okay, so therefore we give this information to the family, and he's very keen to go to see that the people in the company. But Corona has put quite a big full stop for this. Hopefully, when it's all clear, he would try to go. He's more keen about his daughter rather than himself. Okay. So these are some of the mutations that I showed, or variations that I showed in the family, both the father and the son, father and the daughter, and few other members. Okay. Therefore, I'm not going to talk a bit about it. So retinitis pigmentosa, we can definitely provide them genomic testing and counseling, provided there is a clinically actionable choice available. Okay. Now let's look at retinoblastoma. People know about this for the last 40 years. The gene and the testing is now done. Most common pediatric eye tumor, and many of you would have seen this quite often. Two people in the world who are really stalwarts, they dedicated their lives to work on retinoblastoma clinically, genetically as well. Professor Galli and Professor Bowman. Okay, some of you would be knowing them. And they give training, very good to go and get it if you want. Okay, what you see here is a genetic test called as MLPA, and somebody wants to know what more about it. I'd be happy to tell at the question session. What you have to observe here is that this is a region where you have the RB1 gene in the genome, and we get two copies of this, one from father, one from mother, okay, like most other genes. And this red line is the dividing line. And if you have two copies, then you should have this bar going above this red line. Okay. In one of the families, when we tested, we found that in the RB1 gene, which extends from here to here, okay, it was deleted. It's called as microdeletion. Whole gene was deleted. Okay. And only one copy was there. So this is the family that came to us. Okay. And this boy had bilateral blastoma, very early onset, and one of the eye was enucleated, and he was, somewhere close to 2 years by this time this boy was born. And so the father, and after enucleation, boy has one eye prosthetic, and he's quite okay, but had all the chemotherapy, everything. So they really wanted another child. Okay. So one more thing, very important, genetic counseling should not be judgmental. So you should not be judgmental. That's very important. Okay. So you cannot say, look, you already have one child with retinoblastoma, and then at least you have one boy without it. Why do you want another child? Okay. This is not a question a counselor should even think about, leave alone asking. So they came to us to have another child. Okay. Now they wanted to know what is the chance. It's not that the mother was pregnant or anything. Very, very, very good scientist. Okay. And then very, very role model patient. So he wanted to know everything. Okay. He's the man who goes to the Google and gets information and then gives me the call the moment he gets a prompt. Okay. So now what we do is that this was a patient referred by Dr. Mahesh Shanmugam at Shankarai Hospital in Bangalore, India. And he took a look at all of their fundus images. And then, of course, we did this test, genetic test, MLPA test, and found this boy has this mutation. That's the starting point. And Dr. Mahesh Shanmugam took a look at this, all the members of the family, which is mandatory. And then when he looked, he found that there was a regress tumor. Okay. I am not an ophthalmologist nor an optometrist, so you people can see this much better than I can see. Okay. So this is the image of the mother, fundus image of the mother, and then the tumor apparently regressed is seen. She has no visual impairment nor any kind of visual distortion. She is perfectly normal, has no knowledge of this regress tumor. Okay. And this was accidentally discovered when parents were examined. So please, any retinoblastoma child, parents have to be examined. Okay, this is mandatory rule in most Western countries, and therefore please don't ignore that point. Okay. Now we now know the pedigree is like this. So we tested all the 4 members, and we found the same microdeletion in the mother. Father had 2 copies of RB1 gene, and so did this boy. So this boy got the right copy from this mother and the right copy from the father. Okay. But this boy, unfortunately, though got the right copy from the father, got the wrong deleted copy from the mother. Okay. So now the chance of this child getting it is 50%. So we told the family, and they planned for the next child. And then during prenatal stage, we took chorionic villus sampling and tested that, and this was the result. Okay. So all of you can see and give a minute before and judge yourself whether this child will get retinoblastoma or not. Okay. Okay. So all of you did see that it's almost like the other boy, and therefore he has a chance. So there is something called a susceptibility. Okay. Similar to the mother, he could have a regress tumor also. And therefore, in retinoblastoma, there is a susceptibility. And therefore, even if you have a mutation, doesn't mean that you will get the tumor. Okay. So that's how we counseled. But despite all our counseling, the parents said, look, sir, we had such a big turmoil and anxiety, emotion, which was there part of us when this boy had retinoblastoma. So we don't need another child with the same condition. But I told them, see, this time so you can actually start to monitor this child prenatally. Okay, why you monitor them prenatally is that when you do ultrasound, you can see calcified tumor by the last month, the 3rd trimester of pregnancy. You can see calcified tumor, which indicates there is a tumor. Okay. So therefore, I told him that the child will not have any problem with even vision, leave alone the life. But then they were adamant about it, and they went ahead and bought it. Okay, so all things are not fairy tales that happens in genetic counseling. So in retinoblastoma, I'll come to another stage. Okay, it's caused by mutations. Okay, which are heritable. You can test blood and find this out in terms of mutation. There are non-heritable ones like unilateral retinoblastoma and so on, and that this is caused by another gene called as MIC-N, which is something that happens in somatic tissue. Can't check this in the peripheral blood. But then nearly 96% of the times you'll find out the variation or the mutation, okay? And 4% you may not hit anything, okay? So knowledge is very important, okay? So just because genomics is so very well optimized today by a technique called as next-gen sequencing or next-generation sequencing, as a geneticist, you shouldn't think that you can do wonders, okay? So here is a case why I'm saying that. So this is a boy with bilateral retinoblastoma. And this mother who's here, sorry, I'm unable to get my cursor, and I don't know why. Okay, so this is the mother, and this is the boy with bilateral retinoblastoma, one eye enucleated. So they wanted another kid, and without this condition. And father is actually a school teacher in India, and one of our brother's wife is actually carrying, okay, pregnant 6 months. We are doing this counseling currently. So she was concerned about her brother's child, whether it will get retinoblastoma or not. And we did the testing, genomic testing for this boy because they wanted another kid. So it was clinically actionable. We did all tests. We sequenced the RB1 gene. We did not find any kind of variation or mutation. We actually did the MLPA test, the one I showed earlier. Everything was all right. Then we did something called as macro deletion or 13q14 deletion. You all would have studied, which you have to do another test called a site scan, and that was also negative. So we are hitting a roadblock with this family, and the parents are frustrated. We are sitting with them for almost 6 to 9 months. Again, Dr. Mahesh Shanmugam, Shankaraya Hospital referral. And so it's a nightmare, as I told you. It could be the 4%. And as a lab person myself, I know that even simple blood sample switching can create a nightmare. So now we are telling them to do the test again. And big question is who's going to pay for it? Okay, so all this is part of the counseling, and you have to interface with the patient and not the patient here, the family. And at times it can be very embarrassing, and also you feel quite guilty. Okay, nobody is at fault here, but then as a counselor you feel very guilty because the science is like that. Okay, anyway, let me want Usher syndrome, and a couple of cases I'll deal with. Okay, now coming back to the Usher syndrome case, this is a case as you can read it, and it's a very pathetic family actually. The father is a civil servant, government of India, postmaster, and he was living in a rural part of Tamil Nadu. And this disease and Usher syndrome and rehabilitation, progressive loss of vision, deaf mutism, all that brought him to Chennai, urban city, for rehabilitation and putting them in school. And ever since they are in Chennai, and a very pathetic family, lower middle class, very good model patient family. They understood everything. And the reason they came to me was that they came to me, it's very interesting to say this actually. They came to me with a media. Okay. So some of you might know this. There's a Tamil TV channel called Sun TV. They got interested in this family. There was a talk show where they take people with various problems and deal with them. So they invited me into this TV program to talk about the genetics. Okay, it was a bit surprising because they didn't give me much time, and I had to quickly catch up and understand it is Usher syndrome. So let me describe the family: consanguinity, uncle niece, niece sister's daughter, niece married the uncle. Very common in this part of the world, and you can see that first son was affected, two daughters okay, second son or the third child was affected. Simply looking at it might look like a X-linked disorder. Okay, now being a you know with deafness and blindness, uh, he was attending a school. He came across somebody with deafness, not blindness. She had vision, and they fell in love and got married. Okay, so this is very common in a certain kind of disorders, particularly deafness and blindness. People meet others when they go for rehabilitation, and then they get acquaintance, and then they fall in love and get married. Okay, so this lady didn't have Usher syndrome. Okay, the symbol is wrong. Actually, I'm sorry about that. And these two persons were having Usher syndrome. So now the question they had for counseling was that, look, I have this condition, Usher syndrome. Will my daughters get it? Okay. So in my pre-test counseling itself, I told them, look, this is something I told on the TV itself. Okay. And that since this individual didn't marry consanguineously, and she didn't have any visual problem, and this person was not there on the TV program. Okay, it was difficult to ask questions and sense all this with live TV going on. And since she didn't have vision problem, and I could judge it was not Usher syndrome, I told that since it's not consanguineous marriage, these two children will not be affected. And actually one of them, the elder girl, actually had some kind of refractive error, and that refractive error made her have some kind of reading issues, and then the whole family got perturbed, and that's how apparently they got a link to the media, and then went there. So therefore, pre-test counseling itself, we could say these two children won't be affected, but the parents were pretty you know, they cannot express, right? They were blind as well as deaf. So the grandparents were very keen to know for sure that these two daughters won't be affected. And this man never got married, okay, and therefore didn't have children. So therefore we went ahead with the genetic test, okay, because the whole family was quite obsessed. And in fact, the TV channel funded this testing, okay. And then we did the test and found that two hearing genes, okay, one is GPR98 and Usher syndrome 2A, had variations, okay, but this was likely pathogenic and homozygous, okay. This is a very important thing which we can associate with consanguinity, and therefore conclude that this is the gene causing that Usher syndrome, that those two individuals, okay. Um, we didn't do testing for those two girls, okay, because there's no clinically actionable reason. It was very clear even with the variation that we found in the father, and we didn't do that test, okay. This is a guideline that is there in our practice, okay. Let me move to another case, again Usher syndrome. Here we have a girl who's a graduate, 20 years, has both hearing loss and progressive vision loss, and she was being forced by the parents to get married, and she was quite willing, provided that she wanted to know for sure that the future generation will not get same Usher syndrome. Okay, so there's a family tree. They came from interior part of Tamil Nadu. You can see that again, uncle niece consanguineous marriage, and then this girl is affected with Usher syndrome. Then these two people have twins, okay, and are quite normal, right? So therefore, this girl put her foot down and said in pre-test counseling, when I said, you get married outside the family, you won't have any possibility of having a child with the same condition. but she wasn't willing to go with pre-test counseling, wanted the genetic test to be done. And finally, I relented, and then we did the test and found that she had a similar gene, GPR38, which was homozygous because of consanguinity, and it was a pathogenic mutation. So told her, please marry outside the family. And most of you know that in India, we marry consanguinously, and also we marry within the community. Okay, this is a very common practice here. So we get married within the caste, and therefore these heterozygous alleles can be present in the same community, and you can get autosomal recessive disorders. Okay, right. So let me move on to the last part of my talk, the rhegmatogenous retinal detachment syndrome. Now, this is the family tree we are currently handling. One of the parent is a medical professional, and it's not easy. It's from outside Chennai. I'm not telling specifically certain things because of privacy and confidentiality. Okay, so therefore I can't reveal much of information. But then I have to tell why we have to, as a counselor, take a lot of care, because I was a medical professional, the family tree, who was very keen about all this. All right. So let me tell you what the history is. And this is why I'm telling you that taking a very thorough pedigree is very important. And I have very good personnel with me. And this pedigree was taken by one of them, Subhitana, and she takes a detailed pedigree. So I don't interfere. Even if she takes people with presbyopia and whatever, I let her do that without interfering, because at times, she might miss certain critical conditions in the family. Okay. Sorry, I'm taking something to soothe my voice. Okay. Right. So the history here in this family tree is that you have certain members, as you can see here. This is the individual with very severe myopia. Okay, she's 25 years. The mother wanted to find out the chances of this being inherited. And then we took the pedigree, very typical myopia per se. And when we took the family tree, we found that the father also had myopia. And then, as you can see this symbol, he also had retinal tear. Okay, could be easily missed, and then considered to be something not connected between myopia and this. And then detailed family tree also told that the grandfather had retinal detachment. Okay, so that struck a bell that this must be some kind of probably rhegmatogenous retinal detachment. And so if you go into literature, there are many conditions, particularly Strickler syndrome. And what you see in the brackets are the genes involved. And all these things can cause retinal detachment. And therefore, you shouldn't be simply seeing one condition and expecting that it may not be a syndrome. So taking family tree very carefully is very important. We suspect it could be Stickler syndrome because it's myopia as well as retinal pathology in the family. Okay, so we have told the parents as well as the affected person, 20-year-old female. She was shattered a bit. We're still in the process of counseling. And as I told you, we have left the autonomy to the patient and the family to do the genetic test. Okay. So it's still, they've not come to a conclusion whether to do the test or not, because I told that whether you do this test or not, managing retinal issues is going to be not going to be changing. Whether Stickler, Wagner, or whatever it is, it's not going to be different from current management. Okay, so we make everything very clear, and affordability is not a problem here. Okay, because of their background, but then we have left it to the autonomy of the family whether they want to go for this testing or not. But then, as geneticists, we are suspecting that it's not simple myopia, but it's probably a syndromic myopia. We might be correct 90% of the times, but we might be wrong as well. Okay. So therefore, that open-mindedness is very important when we do genetic counseling. Okay, so let me come to the last part of my talk today. So how did this scenario change in the last few decades? Okay, that's what I'm going to talk about, and few other things I'll cover which is associated with this. So let us take that. Let me take you all 30 years behind. I'm sure most of you would not have been alive at that time, but nevertheless, if you are sitting in a clinic, ophthalmology, optometry, doesn't matter, and taking history, and a child comes with cataract, bilateral, and then you look at the parents, whether affected, yes, no, and all kinds of possibilities. There are dysmorphic features. Yes and no. Child is growing now, 2 months, 3 months, 6 months, 2 years. Is there any neurological, neurodevelopmental problems? 2 years child and 3 years, and slowly by that time, you come to know that it's actually part of a syndrome. Okay, because it takes time for the disease to evolve. Now, what happens today, sitting in a clinic? The patient comes with congenital cataract. Okay, go for next-gen sequencing, exome sequencing, you find a syndrome. Okay, craniofacial asymmetry, and there are so many genes for that. And then you know that what it is. Okay, so now you refer the patient, doesn't have any asymmetry yet because child isn't grown very well. It's just a couple of months old. Now, this is the power, and this is the way practice has changed. Okay, next-gen sequencing has done something very amazing, and you've turned the entire flow chart of clinical diagnosis upside down. So now you have a diagnosis in hand, then you start to observe what are the signs and symptoms that are emerging. Okay, that's the way it has gone today, which is for good. Otherwise, it would take ages. And today, even some of the rare cases, if you take, even in countries like US, it can take somewhere close to 4.5 years if you go through the rigorous clinical examination and not doing NGS. Okay, so it can be much worse in countries, of course, like India and China. And there's a big gap of personnel being trained, particularly primary health personnel on genetics. There's a big question mark, and nobody is able to do a big justice of training them in identifying genetic disorders, particularly rare ones. Okay, so that's the reason I'm telling, please ask whether there's any other family history. Okay, very important question that can lead to a lot of solutions, as I showed you with so many cases today to all of you. Okay, so genomic medical service is going to be part of clinical practice in another decade or two. Okay, it's slowly emerging, establishing, putting a foothold in most Western countries. It is cost-intensive service. Okay, it's not something you can really make return on investment. It's more a service because of the infrastructure, the cost, and lack of personnel. Okay, so why is it not being translated from knowledge to practice is because of all of us. We don't ask a simple question, and we think that an untreatable problem, 99% of genetic disorders today are untreatable. But just because something is untreatable, we ignore them. But there are many options, many solutions that in today's genomic world, you can provide these patients and families. Okay, so let us healthcare professionals act as a bridge and not as a wall. Okay, so some of you as optometrists can even pick up the genetic counseling as a profession in ophthalmology. Absolutely lack of personnel. You can get anywhere close to 100,000 US dollars, close to 100,000 US dollars in many industries, not only hospitals, but companies, okay, genomic companies, counseling units, okay, pharma companies, all of them need such personnel. Okay, So there's an absolute deficiency of qualified people who can translate genomic knowledge and pass it over to patients and family. Okay, so look at this as an opportunity. And I did talk with your president, Dr. Fakhruddin, before we started today's talk, that we offer as an organization medical genetics and genetic counseling 6 to 9 week course. Okay, and we did this with Dr. Krishna Kumar's association in Tamil Nadu, the Ophthalmic Optometry Association of Tamil Nadu, and we can do such things for the OOLS if you want to. Okay, and so that you learn this, and you can even pick this up as a profession. You can go to Western world where you get good training today, and then do a master's and become a genetic counselor. Okay, as there's absolute dearth, you will get a job in North America, United Kingdom, Australia, New Zealand, or perhaps any other English-speaking country, for that matter, and perhaps even in Europe, where there's dearth of people. Okay, so please think this as a good option. You can still practice optometry and genetic counseling. Okay, you don't need to quit one for another. Okay, so one small thing, let me expose you to. I spoke about genomics and told that a good fairy tale that this is center of the whole medicine, but that's not the case. Okay, we come to know of late, it's not just the genome, but everything around us, which is called as exposome, which is responsible for us to get to stay in health or get into disease. Okay, for example, the general external exposome, which includes our living environment. It can be home, it can be workplace, chemicals, radiation, so many things around us. Okay, or it can be a specific external exposome like diet, smoking, physical activity. Okay, stress. All right. And it can be something within ourselves, okay, internal exposome, which can be our genome, epigenome, okay, so many other factors, all right? So therefore, all these things put together gets us into a disease state, particularly complex disorders, okay? So as I told you, we have ecosystems around us, lifestyle, which we practice, and social environment, our immediate environment, household, workplace, so many physical and chemical agents which are responsible for us to get disease, right? So therefore, in complex disorders particularly, we have 4 recipes that make us and hold us either in health or disease. Okay, there are uncontrollable factors like genetic risk factors and genetic protective factors, which our ancestors, including parents, handed over to us faithfully. And then how we interface ourselves with the risk, environmental risk and environmental protective factors is left to us. Okay. For example, if you have a gene passed on by one of your parents, like a lung cancer gene, and then you have a risk factor, genetic risk factor, then you interface that with smoking. Okay, so that's the environmental risk factor. So you get the lung cancer by 55 years of age, and then if you live for another 10-15 years, it becomes very severe. Okay, and then you really have a miserable quality of life. On the other hand, with the same genetic factor of lung cancer, if you don't smoke, then you will not get the disease. Okay, or you can postpone it to 75 or 80 years of age. That's okay. Okay, then 55 years of age. Now, this is what is happening today. You can identify just genetic risk factors. Okay, a lot of wrong things are going on here with something called as direct-to-consumer testing and all that. So you have to be careful. That's another area for genetic counselors. Okay, as a profession. And let me quickly finish this, but not that I take too much of time. I'm not going to run through this completely because that's going to take a lot of time. But we can actually look at genomics by gene screening, epigenomics, which is what is happening inside the cell. It can be something called as methylation, controlling the gene expression or the protein folding. All these things is epigenomics. And the mRNA that comes out of the DNA is transcriptomics. Okay, transcription process happens, and that is transcriptomics. And that mRNA becomes protein, and you can study the protein in proteomics. And then that protein involves in the metabolism, so metabolomics can be studied. And then that metabolism actually causes the clinical presentation, health or disease, which is called as the phenomics. Okay, so all this you can actually study today, not only with tissue-related research, but single cell you can see, because the tissue has a lot of other components. It will have connective tissue, and it will have a functional tissue, like say, for example, photoreceptor. Today, you can take one photoreceptor and study one photoreceptor, okay, not thousands of photoreceptors. So you can do this now very well. And this has helped, this technology has helped us to understand human health and disease, okay? So that's the power with which you can work today. You can use this in your genetic counseling practice also. Okay, somebody with a DNA defect of an enzyme, you can look at the protein, you can look at the enzyme, you can look at various other factors, and accordingly help them to get enzyme replacement therapy and so on. Okay. All right. So let me come to the last, almost last slide, which is the summary of my talk. So we went into the basics in understanding ocular genetics and genetic counseling. Then I took 4 different cases and then spoke about it, from retinitis pigmentosa, retinoblastoma, Usher syndrome, and retinal detachment. Okay, so as a genetic counselor, you should have an open mind, and the autonomy should be with the patient, and we should be acting as a bridge between the genomic knowledge and the patient and the family. Okay, that's the most important function of us as a genetic counselor. And it's not difficult at all. Anybody who's an optometrist or a healthcare practitioner can do counseling very well. So we're all sensitive towards patient. Learning counseling is not difficult, but putting genetics into it needs little time. Okay. So then we discussed about how the genetic counseling scenario has completely turned upside down. Okay. So with that, I come to the end of my talk. So let me actually talk about this. I keep myself very active. I eat healthy food. Okay. And of course, today, in the current scenario in the world, you have to keep yourself safe as well. So it's all very important, and don't think that you can be inactive and eat all kinds of junk food and expect that you can still stay parked on healthy side. That's not going to be happening, because whatever is your genome, it will try to hold you on the healthy side. Okay, the epigenome, all the transcriptome, everything will try its best to hold you. But then you cross 40 years, then it will start to lose its power. Okay, so be active, take healthy food, and stay safe, which is very important. I'm glad to know that even Dr. Fakhruddin told me this before the start of the talk, that he went for a marathon. And please at least spend about few hours in your day, or couple of hours in a week to keep yourself active. Okay, so let me thank some of my co-staff members and colleagues, Dr. Uttara and Suketina, Sri Lakshmi, Swati. All these members are very critical for preparing today's talk, and particularly Suketina and Swati. Okay, so Suketina is my co-staff and Swati is one of the interns. Okay, so thank you.
Okay, thank you, Dr. Kumar, for that very informative session. I think it's really enlightening, and thank you for taking us through that pedigrees and also the cases, because that helps in clinical experience, and that helps in looking at what you have come across in your practice and how can we relate it into ours. Thank you so much.
Yeah, thank you, Fakhruddin, and also all the attendees. Thank you very much. It's overwhelming to see that you have about 151 participants. So that's really heartening to see that I could at least spread the message of genomic practice. Please don't ignore, particularly people who want a career break and move on to something else, or people want to do a very good professional practice. Genetics is something you should not ignore. And it's very easy. As I told you, only 4 different types of disorders. Okay, it's not very complicated, quite simple.
That's right.
So, yeah.
So I just let me just kickstart this. So you did take us through the importance of knowing, the history, which is really important, right? You did. I heard you saying this a very numerous number of occasions that please ask your history properly to know the details and the background of the family, and come out with your pedigree charting, which again is like really important in terms of counseling. So how much time ideally do you think you spend on a pedigree charting? Is that a very, we do have a part, to be really honest, we do learn about pedigree charting in our optometric curriculum. We have that basic knowledge, but what do you think is a good time to spend on a pedigree charting?
This question is for me, right?
Yes.
So, the answer for that is that it all depends on the socioeconomic status of the patient and the family. Okay, and how many members have come. So, if there is one generation above member also, then it might roughly take about half an hour to 45 minutes to get a good pedigree. Good pedigree is like the one I showed about the retinal detachment pedigree. Okay, so half an hour is enough. Again, it depends on very many other factors, like whether you're doing it offline, online, and so on, connectivity and other issues. But basically, the answer for your question is half an hour.
Okay. And I think I did also understand that you normally want to not do the whole thing in terms of counseling in one session, because as you said, they might go back and they might get some new information while you are talking to them. And next visit, you might have to modify the pedigree again if they have some new information, right?
Correct.
So,
yes.
That's right. Yeah. So I think if we wanted to relate to optometry, because we normally play a very important role as a frontliner, because when patient walk in, we are the one who are the face of practice which we are working in. So we do a lot of talking, right? We do a lot of talking. And I think there are a lot of students here, so probably we can just emphasize on this, because and I think you emphasized it a lot already, that history taking is really important. You can't be going, you can't be sitting down and just testing eyes, but knowing patient's problem, whether it's for your eye testing or for the overall management, is really important.
Yeah. So since you mentioned this, Fakhruddin, I had actually got very close to the optometrist, of course, in Shankar Netralia, as well as in Aditya Jyotai Hospital in Mumbai, and taught them how to take pedigree and emphasize the importance of genetics. So over a period of time, I was starting to see that the optometrists were drawing pedigrees, okay, which was very nice, heartening to see that.
Yeah.
And because the first line of defense in the ophthalmic hospital, patients will like to tell so many things to them and open out. And therefore, please, as I told you, ask this question, any other member affected. And once they say yes, please draw a pedigree. Okay, so that is very important. And there were a lot of people who were very much interested in doing genetics in Mumbai as well as in Shankar Netralia. Okay, so yes, thank you.
Great. And I think one of your student is also attending. A student means somebody who had attended your session and is now recommending it. So I'm really pleased to see that even after they've attended the whole course, they are still attending the session because they like to learn from you. And each time you talk to us, it's enlightening. So
yes. Yes, that's Devi actually. She's an optometrist, seasoned, sort of a senior optometrist,
Yes.
and I appreciate her comment. Yes, so of course, learning new thing makes you quite excited, not necessarily genetics, but anything for that matter. And this genetics will be very useful for your optometric practice. I can assure you that. Okay. So even if you ask a simple question, is there someone else affected in the family, will make the patient and the family to bind with you. So they'll be surprised. Okay. And so, like, for example, a couple of weeks ago, we were talking about online. Okay. Patient was elsewhere in India. I was in southern part of India, Chennai. And so the way the patient, see, this is a problem with online practice. Okay. I felt the patient was obese with RP. So I simply asked a question, do you have any extra finger? And that really stunned that mother. And she was till the end asking me, how come I asked that question? Okay. So therefore, we should be quite open and, always think that at least 10% to 20% of your patients in optometry practice will have some syndrome. Okay. Particularly when you're in an urban city, they'll really have many difficulties, and then they'll come. Okay. So in my counseling practice, when I do talk to visually challenged people, particularly with visual impairment, I will cover my lips when I talk to make sure that they don't have any hearing problem. Okay, because many of them can lip read and find out what you're telling. So therefore, and when they turn around for whatever reason, I'll ask a question, so that if they have hard of hearing, mildly, okay, then you'll know that they have a hearing problem. These are simple things which you all can practice and find out Usher syndrome. It's very, because Usher syndrome has 3 to 4 types. One of them is very mild hard of hearing. Okay, they don't even need a hearing aid. Okay, so let me actually deal this as a question, in fact. So the question is that out of the 4 listed, which one is not a chromosomal disorder? Okay, so just think about it. And I'm sure you would have learned about Klinefelter, Down syndrome, Turner, and Duchenne. So Klinefelter is, they are excessively tall, and mostly they are infertile. Okay. Normal intelligence they have. Down syndrome, obviously, you all know. You might have seen them as well.
Very common into our practice.
Yeah, that's correct. And particularly pediatrics, you will come across them. And so when we see Down syndrome children, we are what we counsel, let me tell you, is that these children, particularly females, are subfertile. And they have mental challenge, and they can be exploited. Okay, female children of Down syndrome. So I make it a point to tell, though nothing genetics about it. So therefore, they can be sexually exploited, and they won't even know. Just ice cream can make them. They can lure them with an ice cream. Okay, so you have to be telling these social points. In a country like India, I do that. Okay, maybe in the US there'll be a social counselor separately who'll take care of it. So of course, Turner syndrome, they have only one X chromosome, and therefore still they are a female. And of course, they'll be missing their periods, or they wouldn't have one, and that's the reason they come to hospital. Since they don't menstruate, don't reach menarche. Duchenne muscular dystrophy is a muscle problem, and it's called as pseudohypertrophy. You would hardly see them in an eye hospital. Most researched in genetics similar to retinoblastoma. And we know every bit of Duchenne muscular dystrophy genetics, and they're trying gene therapy today. And that's been on the cards for a long time. But because eye is an exclusive organ, gene therapy became more successful in ophthalmology than any other fields of medicine. Yeah.
Okay. And the other question was on that. I guess you can see the
Yes,
second question. Yeah. Okay. Great.
hemophilia. Hemophilia is a bleeding disorder. As you know, that there are several uh, bleeding and clotting factors which are very important when we meet with an injury. So there are vascular factors which will constrict the vessel to stop bleeding, and there are clotting factors which will try to block that injury site so that the bleeding stops. So therefore, in hemophilia, people lose particularly one factor, uh, can be factor 8. Okay. And therefore, people give that as replacement. These children counseling is very difficult because right from very young age, they need to be replaced with blood factor 8. And therefore, what happens is that they are prone for various infections because of this sort of transfusion. And initially, some time ago, 3 decades ago, these children got HIV also because at that point of time, whole blood was given to them. Okay, so therefore, it's a complicated disorder, autosomal recessive disease. Okay, um, and therefore, this is a condition that I don't see much of it, but you could see them with bleeding spots in the retina and so on, for which they may come with visual disturbances.
Okay. Okay. Great. So that helps. And let's look at the next question. Yep. There you go. I have put it up. Yeah.
Yeah. So as I told you, genetic counseling is very easy and precise in chromosomal disorders, single gene disorders, and also mitochondrial. Okay, it's very complicated in complex disorders. But more and more people will come into complex disorder genetic counseling because my era, I have seen only mostly these three categories, as I said: chromosomal, single gene, and mitochondrial. Mitochondrial also started to emerge in the second part of my genetic career, I would say. Um, so the whole field of the history of genetics, medical genetics, started with chromosomes, 1960 onwards, and then people discovered Down syndrome and Kleinfeld Turner. So that's big research that time. And two top countries in the world were Paris and London, not US. Okay, and then currently US is on the top. So, and then by 80s, single gene disorders came. People are finding out some of the X chromosomal genes. And then when end of last century, around 1990s to 2000, a lot of genes were discovered, particularly in the eye. So I was there at that time, and as I told you, RP65 was one of the genes our group found. And now gene mapping is almost history, and therefore I'm glad it came into clinical practice with genomic diagnosis and so on. But then what is disappointing is we thought that gene therapy will come into existence by the end of last century. But we have crossed 2 decades now, but still gene therapy is struggling. Okay. Uh, so alternative therapies like cell therapies are coming in. But again, there are many issues, and that's a talk, separate talk by itself. Okay. Uh, right.
And let's look at another one.
Mm.
Multiple genes in which condition? So,
Okay. So there are many characters which are we don't know still, and we escape by saying multiple genes. But in certain things, they have found out multiple genes. Okay. And if you take the iris color, okay, there are a couple of genes there. So of course, one secretes the black pigment. In most Asians, we have a black iris. and very little black pigments or may show up as brown pigments. Okay, and of course you have the blue and the green. Okay, um, so therefore that is very complex. Of course, heterochromia is another genetic condition, and you can really have many Waardenburg syndrome, as you know, can have heterochromous as one of the phenotypes. Yeah, okay.
And one last question was on particularly on retinoblastoma. And yeah, I think you did cover some aspect of this in your session. Yeah.
Yes. So yeah, retinoblastoma is an amazing disease, and all of you know that it's 1 in 25,000 children, 20 to 25 are affected. Extremely rare in that way, compared to say leukemia or hemophilia and so on. But people researched on that. Okay, so what I'm trying to say is something being uncommon doesn't mean that it will not throw a huge amount of light and knowledge. Okay, when they discovered retinoblastoma, they didn't know an entire field in oncology. Okay, so until then, what they knew was cancer genes, or called as oncogenes. So therefore, they thought that only cancer genes cause cancer. When retinoblastoma was discovered, a new avenue was opened up. I can't tell that because that will give you the key. And discovering retinoblastoma made people discover another 35 genes of this nature. Can you believe it? So the mechanism by which retinoblastoma is caused in 35 different types of conditions. Okay, for example, breast cancer, neurofibromatosis, and there are many conditions. Okay, there's another condition called as Lee-Fraumeni syndrome, causes multiple cancers in different parts of the body. So therefore, one gene which is so uncommon, research led to finding out 35 different types of other genes which cause the same mechanism. You know that Knutson's hypothesis, right? Two-hit hypothesis. And he was another amazing man. I have met him, Knudsen, Alfred Knudsen. And so his discovery, they proved that it is causes retinoblastoma. And another 35 different human genetic disorders are caused, including breast cancer, by the same two-hit mechanism. Okay. So therefore, when somebody applies for research fund, you should not be very focused, because I do see such applications for funding. So you should have an open mind. Just because something is very rare, you shouldn't think that what's the purpose? It doesn't affect many people. Okay, that's a very bad closed-mindedness. Okay. Okay. So I can come out with the key if.
Yes. Yeah. So I think we have received most of people who have submitted their Google form. So I think we can just come out with the key, and we can
start from the beginning. Oh, that's the first question. Okay. So choose an option that does not represent chromosomal disorder. Klinefelter is XXY. That's a chromosomal disorder. Down syndrome is trisomy 21. That's another chromosomal disorder. Turner syndrome is 45X. In fact, I did tell that by mistake, but that's it doesn't have another gender chromosome. Okay. So all these three are chromosomal disorders. Okay. The only one, which is the Duchenne muscular dystrophy, is a Duchenne gene, which is an X chromosome. So it is inherited and it affects only the males. Okay. So whoever has ticked the D is right.
Right. Okay.
Okay.
So D is the correct answer. Okay.
Yes, I really appreciate people who ticked it correct, because I never touched that subject in today's presentation. So my presentation and the questions may not match very much, okay, but I really appreciate you people having a good genomic knowledge. Okay. Right. So let me take the second question. Hemophilia is more common in males because it is a what kind of disorder? So recessive character carried by Y chromosome. Okay. So Y chromosome really doesn't carry any defective gene, okay, except for infertility. So the Y chromosome actually carries a gene for making a bipotential fetus, okay, intrauterine, into a male. So left alone, an embryo will develop into a female child. Okay. So if you have a Y chromosome, that fetus will become a male fetus. Okay, there's a gene for that. Otherwise, it doesn't carry any gene. So obviously, it doesn't carry the hemophilia gene, though it affects the males only. Okay. So therefore, Y chromosome B option is also not there. And the third option, yes, I told you it's a disorder that is inherited in males, and therefore it has to be in X chromosome because we get X from our mother and Y from the father. We, in the sense, males. Okay, that includes me. Now, if you're a female, you get X chromosome from your father as well as one from your mother, out of the two from your mother. Okay, so therefore, X is always inherited by a male from the mother, and the other X which a female has, a male doesn't have. So if you carry a mutation in the X chromosome as a male, you don't have a compensating same gene, normal gene, in the other X because we have Y. Whereas a woman carrying a recessive single gene mutation, not in a double dose, but in a single dose, since she has another X chromosome, will be normal and a carrier. Okay. And dominant trait of an X chromosome will be inherited by both males and females, and not exclusively by males. So therefore, the D answer is correct. Hemophilia is a recessive trait carried by the X chromosome. The same X chromosome also carries the color vision genes, okay, particularly red-green. Red-green is present in X, and therefore you have color blindness only affecting the males. Okay, the blue color is present in chromosome 10, I think, and it's an autosomal type. Okay, now let's move on to the third question. An abnormal human male phenotype involving an extra X chromosome, XXY, is a case of Edwards syndrome, is actually trisomy 18, hardly seen in ophthalmology. Klinefelter is actually the answer, XXY. They'll have 47 chromosomes in XXY. Intersex is another. So sex is actually a spectrum of, gender is a spectrum of phenotypes. Okay, you can have completely male like most of us and completely female like most of you. Okay, and in between there are people who have various features. Okay, and one of them is intersex, and that's a very crude term. It's called as hermaphrodites. Okay, that's a subject by itself to discuss. And obviously, Down syndrome is trisomy 21, not sex chromosomal disorder. So Klinefelter and Turner syndrome are sex chromosomal disorder. In Klinefelter, we have 2X and 1Y. Okay, B is the answer. Yes, next. Question 4. In human beings, multiple genes are involved in the inheritance of sickle cell anemia, skin color blindness, phenylketonuria. So the most likely answer obviously is not sickle cell. Sickle cell is one single gene disorder. Single skin color is 8 genes roughly, and it's a melanin pigment, tyrosine pathway related skin pigment is produced in that pathway, and therefore there are several genes involved in it. Color blindness, of course, there are 3 genes, red, green, and blue. Okay, but then it's much less than skin color genes. Okay, so the correct answer is skin color is B. But if you had ticked color blindness, that's also fairly correct because multiple genes are there. So B or C is correct. D is wrong. Again, phenylketonuria is a single gene disorder.
All right. Okay. And let's move to the last one here. Yeah. Retinoblastoma is, which is the correct one?
Yeah. It's associated with loss of short arm of chromosome 3. Is caused by mutation in growth suppressor gene. Is an autosomal dominant condition. Okay. Is sporadic in the majority of unilateral cases. Is inherited in a majority of bilateral cases. So the right answer, very strongly right answer, is it is an autosomal dominant condition, which is C.
Yeah.
Okay, this is a little tough question because most of them are actually, C is the right answer.
Yeah.
Most of them are actually fairly does correlate with retinoblastoma, but the most likely one is so yeah, because mostly in the VQE ECFMG exams in the US and also the PLAB test in Britain will give you all the answers will be correct, but the most likely one is what you have to take. So really speaking, C is the right answer.
All right. Okay, great. So I think with that, thank you so much, Dr. Kumar, for that wonderful talk. And I think I do understand your time, and thank you so much for staying back with us and discussing the answers. And the most important point here is telling us why this is the correct answer. That's also important for us to know, right?
Yeah. Yeah. So that's why I said I'll do it because
More easier.
Yes. Another excuse of me with my time, actually.
Yeah.
Okay. So let me thank once again Dr. Fakhruddin, the online optometry learning school, and all the attendees today. It was really heartening to see quite a big number attending the program. And thank you very much. And in case if you are interested in anything else, please let Dr. Fakhruddin know that.
Sure,
Thank you. Thank you all. Thank you, Fakhruddin.
Most welcome, Dr. Kumar. And just to be reminded, we do have a session tomorrow as well at Online Optom Learning Series. So please join us tomorrow. The session is at the times mentioned according to the different time zones. Until then, take care, be safe, and I hope to see you tomorrow. Bye-bye.
Thank you. Bye.
Thank you, Dr. Kumar. Bye-bye.
Thank you. Thank you, Dr. Fakhruddin, and the rest of you. Thank you very much. Bye.
Most welcome. Bye-bye.